Our next speaker, Professor Dr. Richard Wiggins, Associate Dean of CME and Professor of Radiology at University of Utah, a leader in neuroradiology and imaging informatics. He has authored over 60 papers, 11 books, and 100 book chapters, delivered more than 600 lectures worldwide. He has served as a president of American Society of Head and Neck Radiology and the Western Neuroradiology Society, and chaired the Society of Imaging Informatics in Medicine. A celebrated educator, he has received the RNA's Honored Educator Award and is a fellow of the American College of Radiology. Please welcome Professor Richard Wiggins. Okay.
Thank you. Thank you so much. Thank you very much for the invitation. It's great to be here. So we heard earlier about congenital hearing loss. I'm going to talk about acquired hearing loss. And we're going to review all these cases in the important anatomy and how we think about acquired hearing loss and how we image it on cross-sectional imaging. And like a lot of areas around the temporal bone and skull base, we're going to see how CT and MRI are complementary to evaluate these areas. So I have nothing significant to disclose. We're going to look at how we use these imaging modalities, CT and MRI, to evaluate acquired hearing loss in these cases. Now, we already went over some of the anatomy, so I'm going to focus on the pathology of these cases. But we think first about hearing loss. This is a big discussion when we think about which modality to use. And like everything else in the head and neck world, we want to get as much clinical information as we can to evaluate these cases. So we try to find out from our clinicians what exactly is the history and what do you see on otoscopic exam actually in the ear when you look in for these acquired hearing loss cases. So we heard about congenital and all the syndromic factors earlier from Dr. Schroff. I'm going to talk about the acquired and the spectrum of what we see with acquired hearing loss. And one of the first questions when somebody calls and asks about the evaluation of a hearing loss case, what kind of study should I do? What kind of modality? So we have sensor or neuro hearing loss, and we have conductive hearing loss, and we sometimes talk about a mixed hearing loss. Now, if it's from somebody who knows what they're doing and you're sure that that's definitely conductive or sensory hearing loss, we think about that evaluation. If you say sensor or neuro hearing loss, we're thinking about doing an MR. And if you say conductive hearing loss, we're thinking about doing a CT. So that's an important distinguisher right away. And I'm thinking about each step along that pathway that you heard about earlier. So if somebody says conductive hearing loss, I'm thinking about a problem from the windows out. So I'm going to look at the EAC, tympanic membrane, all the ossicles, and all the way up to the oval and round window. If you say sensory hearing loss, I'm thinking about a problem from the windows in. So the oval and round window, the inner ear structures, the internal auditory canal, the CP angle, and the brainstem. So I'm going to evaluate those areas. Now, for me, if somebody says conductive hearing loss, I'm going to do a CT without contrast within sections, and I'm going to think about increasing my sensitivity. So I'm going to keep looking until I find something that looks like it's wrong on that study. Is one suspensory ligament a little thickened, or is something just not quite seem right? So I'm not going to give contrast for those studies. If somebody says sensory hearing loss, I'm thinking about doing an MR, and unless they have red flags, like increasing pain or another cranial nerve deficit, I'm just going to do a CSF bright sequence. Whatever vendor you have, if that's KISS, Fiesta, T2FSE, SPACE, whatever that sequence is for you, that's a CSF bright sequence. That's the study we're going to do. And we do axial and coronal. If you do a SPACE acquisition, you can just acquire in the axial and reconstruct coronal and sagittal images. So that's a big differentiator right at the beginning. If they say conductive hearing loss, I'm doing a CT, and I'm going to keep looking till I find something. If I don't find anything definite, I'm going to say, this suspensory ligament looks a little thick. I'm most suspicious of that. And how the neuro-ontologists actually evaluate doesn't sound very scientific. They'll actually go through the TM and grab the ossicles of the pair of tweezers and wiggle it to see if they think it's fixated or not. So that's how they evaluate it. If they say sensory hearing loss, then I'm going to do an MR in those cases. So that's an important differentiator right at the beginning. So we heard about the anatomy earlier, so I'm going to focus on the pathology, and I'm going to start I like to start on the outside and go in. So we're going to look at the external auditory canal and some pathologies there. Then we're going to look at the middle ear cavity, then the inner ear structures, and then CP angle IAC. Anything along that course is what we think about for acquired hearing loss in those pathologies. So first, the external auditory canal. So first we have keratosis obturans. Usually these patients are under 40, it may be bilateral, and we see a soft tissue defect filling the external auditory canal itself. The osseous walls look okay, they're not destroyed, but I have homogeneous soft tissue filling the external auditory canal in those cases. On otoscopic view, if they look in the ear, they just see a big keratin plug. They can't see down to the tympanic membrane on otoscopic examination of those cases. So here's a case with the axial bone on top and the coronal bone on bottom, and we see soft tissue from the tympanic membrane filling the external auditory canal on both sides. So here in the same thing on the coronal, the TM looks fine. We see a normal scutum, we see a normal tympanic annulus, but there's soft tissue filling the external auditory canal. But the osseous walls look okay. So that's a good example of keratosis obturans where we have soft tissue filling it. And that's soft tissue density. I have this CT scanner, it's just a big, stupid densitometer. I'm just looking at densities of stuff. There's some soft tissue that's filling the EAC. So that explains to me why those sound waves are not getting through the tympanic membrane. So next we have medial canal fibrosis. Here we have this fibrous material in the medial external auditory canal, and we have a crescent out laterally. And it may be bilateral in about 60% of the cases. So here's a coronal graphic. We may have a little skin thickening. Again, the middle ear structures are fine, but we have this medial canal fibrosis. There's fibrotic material that's pressed up against the TM with a crescent out laterally on imaging. That's great for medial canal fibrosis in those cases. So here's a case, a coronal CT on top and the correlating axial on bottom, and we see that crescent out laterally with this soft tissue that goes all the way to the tympanic membrane, but the middle ear cavity is still normally aerated. So that explains why this patient would have a conductive hearing loss with medial canal fibrosis in that case. So we have a spectrum when we think about infectious and inflammatory processes of the EAC. Is there anything like debris or a foreign body in the external auditory canal, the ear hole, that might be blocking the sound waves from getting the TM? If I have scalloping of the inferior EAC, half of the cases have bony flecks left behind, that's a good appearance for an EAC cholesteatoma. If I have an older patient, over 80, say, maybe immunocompromised, often with a Pseudomonas aeruginosa infection, they may get necrotizing external otitis, what we used to call malignant external otitis, and they can get infection that goes down inferiorly through the fissures in the cartilaginous EAC to the parotid. So that's a good appearance for necrotizing external otitis. If I have soft tissue filling the external auditory canal, that's a good appearance for keratosis obturans, and I just have a crescent laterally and a little bit of soft tissue pressed up against the TM, that's a good appearance for medial canal fibrosis. So that's my spectrum of acquired hearing loss possibilities in the infectious inflammatory range of the external auditory canal. Now, if we have repetitive exposure to cold water, we sometimes think about surfer's ear or osseous exostosis. So repetitive response to cold water, and people for us surfers or scuba divers, and they get bony overgrowth. So it's a bony stenosis of the EAC with thickening of the bone, but normal overlying skin of the external auditory canal. So here's a coronal graphic, and we see osseous expansion of the bone. So the bone is bigger. That's very important when we think about temporal bone as well as skull base. The words we use to describe the osseous changes. Is it permeative destructive? Is it expansile? Is it sclerotic? Is it increased density? So we need to be very careful about those words we use, because sometimes as soon as you use one of those words, especially at the jugular foramen, you're going in this direction. You're thinking about that pathology. And you may start to apply imaging findings that are not there to that study itself. So on otoscopic exam, we see circumferential under the skin narrowing of the external auditory canal. So here's an actual otoscopic view where you see that. So the skin looks normal overlying it, but you have osseous overgrowth. So repetitive exposure to cold water, we think about exostoses. And here's a case, axial on top and coronal on bottom, CT, where we see this osseous overgrowth narrowing the external auditory canal. Again, if those sound waves are not going into the EAC, we're going to have a conductive hearing loss on that case. So that's the external auditory canal, what we think about. So now we're going to move to the middle ear. So we have this box. We think about the tympanic membrane on one side and the oval and round window. We've got 3 ossicles. We have 2 muscles, the stapedius and the tensor tympani, and we have 4 suspensory ligaments that we most often see. Sometimes the neuroodontologists say it's variable. There may be up to 8 suspensory ligaments holding them in. But anything that affects any of those structures and their movement may cause a conductive hearing loss in those cases. So as you heard this morning, we think very closely about CT scans in those axial sections. We want to see a good ice cream cone and then 2 dots, a colon, and then kind of an equal sign down lower. So we want to evaluate those ossicles and see if they're all there and look normal. If there's any pathology that may be obstructing their motion, they may have conductive hearing loss. Frequently, we're thinking about cholesteatoma. Is there skin in the wrong place? So we may get a retraction pocket from the TM that may go in, and then we have skin debris that's within the middle ear cavity obstructing the motion of the ossicles. So on physical exam, they see a white mass behind an intact tympanic membrane, and we think about it as just as an aberrant epithelial rest. It's just skin in the wrong place. So here's a coronal graphic. We have the tympanic membrane. Now the external auditory canal looks okay, but in the middle ear cavity, we have this pearly white mass behind an intact tympanic membrane and a patient with a conductive hearing loss. So on otoscopic exam, the tympanic membrane is intact, but we have a white mass behind the intact TM. If that patient has a conductive hearing loss, that's a great appearance for a cholesteatoma that's in the middle ear cavity. So we think about a destruction of those ossicles and the surrounding otocapsule. This is the otocapsule, densest bone in the body, so that bone should be bright white. So it's very important when we're looking at temporal bone CTs to have a much wider window than other structures that we think about. We want a window level setting something like 4,400, so we can see these subtle osseous changes around the cochlea and the vestibule and the semicircular canals. So here we look at the ice cream cone and we see some destruction of the cone and a soft tissue mass next to it. So that's a great appearance for a cholesteatoma. That's just crazy. Nobody would eat the cone first, right? Any kid you give an ice cream cone, they're never going to eat the cone first. They're always going to eat the ice cream. Nobody would do this. So that's a great appearance for a cholesteatoma with some ossicle destruction of the short process of the incus, the ice cream cone, back behind the ice cream scoop. That's the head of the malleus. So we're often trying to differentiate inflammatory debris, and we talk about mastoiditis, we'll talk about in a little bit, and these discussions can get very confusing because, again, CT scanner is just a big, stupid densitometer. We're looking at densities of stuff. So is it soft tissue or fluid density? It's hard to evaluate sometimes on CT to differentiate those. But we're trying to think about the spectrum of inflammatory processes. And usually we just have fluid. We have a little bit of respiratory mucosa inside of the middle ear and the mastoid air cells, and that can leak a little bit of fluid that we have around there. So there's no osseous destruction, there's just some fluid density within the middle ear or mastoid air cells. And we often see linear strands of soft tissue that may be partially obstructing the middle ear cavity, but all the bones are intact. We don't see any ossicular destruction, and the ossicles look okay, the inner ear structures look okay, all the bones look like they're still there and normal. So we're trying to differentiate this. I'm looking at all these air cells and I'm trying to think, is this just an air fluid level with some fluid, or is there actually some osseous destruction that tells me there may be a coalescent otomastoiditis, for example, in that case? Now, if I see some osseous destruction, here I see the head of the malleus, I see the ice cream scoop, but there's no cone behind it. I've lost the short process of the incus. So that's a great appearance for a cholesteatoma. And if I completely lose the ossicles, here we're at the level of the vestibule and the lateral semicircular canal. When I'm at that level, I should see the ice cream cone. And I don't see the ice cream cone here, there's just soft tissue. Somebody ate the ice cream cone before I got there, that's very sad. So I don't see the ice cream cone on that case. So that's a good appearance for a cholesteatoma. And if there's a lot of destruction into the external auditory canal, we may have some soft tissue that's eroding into the canal. It might look like a postoperative case. So we might start thinking, is this a canal wall up or canal wall down mastoidectomy? But if the patient's never had surgery, that's a good appearance for a cholesteatoma at that level. So we can have acquired cholesteatoma that we think about as the pars flaccida or pars tensa. The acquired is usually a younger patient and they have some kind of disruption of the tympanic membrane itself. So the pars flaccida we think about is more common, that's the primary type. The pars tensa is the secondary, and different retraction pockets. Is it coming up medial to the ossicles or lateral to the ossicles? So for the pars flaccida, we think about this retraction pocket up on top at the pars flaccida, the superior portion of the TM, and that retracts back up into the lateral epitympanic space or recess or Prusak space, if you like to name stuff after people in medicine. So we think about that eroding the scutum laterally and eroding the ossicles medially. If we have a pars tensa, that may retract up medial to the ossicles and it may push them out laterally. So depending on where we see that soft tissue, medial or lateral to the ossicles, it might guide us, is that a pars flaccida or a pars tensa cholesteatoma? So CT is really our study of choice for these cholesteatoma cases, and anytime we see a non-dependent homogeneous soft tissue mass anywhere in the middle ear cavity with some kind of osseous destruction, we're going to think about cholesteatoma. So if we see that, a non-gravity dependent homogeneous soft tissue mass with a destruction of something, 90% of the time that's going to be a cholesteatoma in the middle ear cavity. On MR, we look for a non-enhancing mass. It's kind of iso to muscle on T1, a little bit brighter on T2, and it doesn't enhance, but there's some enhancement around it. So on otoscopic view, here's a good pars flaccida, so we have a retraction pocket up high with that pearly white mass that's superior to the tympanic membrane. And we think about complications. So if the cholesteatoma is destroying different structures, we may have different clinical presentations. They may have meningitis, they may have a fistula if they erode into the middle ear cavity, and we think about all the surrounding structures. So when we have a cholesteatoma case, we have checkpoints that we want to go through and talk about, as you heard earlier. So we look at the roof, the tegment tympani, is that intact? We think about a fistula formation, does it erode through the otic capsule? We look at the facial nerve tympanic segment, is that destroyed or eroded? We look at that sinus tympani, that important area in the back wall we heard about earlier, because we try to tell our surgeons if that's involved in that case. Next, we have tympanosclerosis. If we have chronic infection of the middle ear cavity, it sometimes looks like we have little calcific debris laid down over the ossicles and or the tympanic membrane. So the TM may be thickened with calcification in it, and they may have a conductive hearing loss that's kind of out of proportion to the amount of disease that we see, but we look for those calcifications. So here's a coronographic tympanosclerosis. It looks like we have a lot of extra bumps on the ossicles themselves, and we may have irritation of the inside lining with thickening and calcification of the TM itself. If that goes on for a long period of time, we may have a siccular destruction, so when we've destroyed the chain. So obviously that patient's going to have conductive hearing loss because we're not going to be transmitting the motion between the ossicles themselves. On otoscopic view, here's a perforated tympanic membrane, and instead of seeing the normal ossicles, we have all these extra calcifications back behind it. So here's a correlating CT case, axial on top, coronal on bottom. So instead of just the ice cream cone, we have all these extra bumps, calcifications along the ossicles themselves. So this is an ice cream cone with sprinkles. You might get sprinkles on the ice cream and on the cone themselves. So there are all these extra bumps around that area. So if we see that, we think about tympanosclerosis. This is old infection of the middle ear cavity. Next, we have cholesterol granuloma. Clinically, we see a blue retrotympanic mass, but the patient does not have pulsatile tinnitus. And we think about this as post-inflammatory granulation. The surgeons say there are these brown crystals. It looks kind of like fat globules in that area. But on imaging, we like to see the bright T1 and T2 signal intensity on MR that helps us differentiate these cases. So that tells us that's a cholesterol granuloma when we see that. So we look for a soft tissue mass that's filling the middle ear cavity. We might have lost the ossicles in this case, and we try to look at both CT and MR. So on MR, we look for the bright T1 and T2 signal intensity. Not a lot of things are bright on T1, so we have to put in one of those categories. Is it fat? Is it proteinaceous material? We talk about melanotic, bright T1 signal. If somebody has melanoma, we sometimes talk about melanotic and amelanotic types of melanoma. So not a lot of things are bright. If we do fat saturation and it stays bright, I know it's not fat. If I haven't given gadolinium yet, I know it's not an enhancing lesion. So a great example of in the head and neck world, you really have to put the T1 pre right next to the T1 post and compare them side by side to see what was bright before contrast. And it's very important to pay attention to your fat saturation after contrast. So I like to do not fat saturation on my T1 pre, and I do fat saturation after. So I think it's important to see, just like everything else in the head and neck world, where there is air and where there is fat is very important in all these pathologies. So next is labyrinthine ossificans, you heard about earlier. Anytime we have increased density on CT, or we lose the CSF-like bright signal within the interior structures, the cochlea, the vestibule, and the semicircular canals, we think about labyrinthine ossificans. Usually we think about this as a post-inflammatory ossification, but it can be infectious or post-traumatic. So oddly, if you do surgery, if you breach the otic capsule, or if you have trauma, or if you have infection, or sometimes if you cut the nerves to the interior structures, you may end up with labyrinthine ossificans. So on CT, we see increased density within those interior structures. So here's the cochlea, here's the vestibule. We should have fluid density in the vestibule and the lateral semicircular canal. We see on both sides increased density in those structures. And on MR, we lose the CSF-like bright signal. So we think about that perilymph and endolymph that we heard earlier. It should be similar on density on CT to CSF, and it should be similar in signal intensity on MR to CSF on our T2 bright images. KISS, Fiesta, T2 FSE, SPACE, whatever vendor you have in the type of sequence that you're doing. Now, if we do surgery, like this patient who had a translabyrinthine approach to the ear, you see the pre-op imaging, we have fluid density in the basal turn of the cochlea on this long axis or Stenver's projection. But after surgery, and there's this wide range, 3 months to 3 years, when we start seeing labyrinthine ossificans, you might see increased density within those structures. So when we see that, that's a good appearance for labyrinthine ossificans. Next is otosclerosis or otospongiosis that, again, you heard about earlier. We think about the fenestral and the cochlear type. So the fenestral is thought of as the more common, about 90% of the cases, and they present with progressive conductive hearing loss. The cochlear type may have progressive sensorineural hearing loss, and then they also may present with mixed. So with the fenestral type, we think about that fissula antifenestrum, the small fissure in front of the window. So where we think about the oval and round window, if you find the basal turn of the cochlea and you look anterior to that laterally, that's the fissula antifenestrum. And again, this should be otic capsule, should be dense as bone in the body. So it should be very bright white bone all the way around the cochlea and the vestibule in these cases. So with fenestral otospongiosis or otosclerosis, we have replacement of the normal bone with less dense bone. So we may impair the motion of the stapes at the window at that level. And on imaging, this is that fissula antifenestrum you heard about this morning. So you see how easy this is to miss if you don't think about it. If you do hear from your clinicians, there's kind of a pink or reddish blush above the cochlear promontory. Some people call it the pink flamingo sign or the rising sun sign. That we think about that, the fissula antifenestrum, the small fissure in front of the window in those cases. So the cochlear type is we lose the density all the way around the otocapsule around those structures. So some people think about this as a spectrum. We start with fenestral, just at the fissula antifenestrum, and over time, if you wait long enough, you may have lucency all the way around the cochlea and the vestibule and the semicircular canals. So we look for these focal lucencies that may be around those structures. So here's an axial graphic where we see we've lost the normal density of the bone. And again, this is very important. When we do temporal bone CTs, we want thin sections, and you need a much wider window, something like 4,000 and 400, to see these subtle osseous changes around that. Otic capsule, densest bone in the body, should be bright white around the cochlea and the vestibule in those structures. So here's a nice case of cochlear otospongiosis, where we have decreased density all the way around the cochlea and the vestibule and those structures. But again, you have to window that with a very wide window to be able to see these changes. If you're using 440, something like a soft tissue window, you may miss this on a temporal bone CT. So the window level setting we start with is very important. Next, we have osteitis deformans or Paget's disease. We think about these waves of osteoblastic and osteoclastic reaction that may go through the bone. And we think about the cotton wool appearance and expansion of the osseous structures. Paget's, or osteitis deformans, doesn't respect the otic capsule like fibrous dysplasia does, so those changes go right through the otic capsule all the way down to the cochlea, and they may present with a sensorineural hearing loss or mixed hearing loss. So here's a case where we think about those waves of osteoclastic dysplasia, osteoblastic and osteoclastic activity with enlargement of the bone, but very different than fibrous dysplasia, where the otic capsule is intact with fibrous dysplasia. The expansile changes and ground glass changes of the bone. With Paget's, or osteitis deformans, those changes may go right up and touch the cochlea. So that's sometimes helpful to differentiate between osteitis deformans or Paget's or fibrous dysplasia, because fibrous dysplasia will respect that otic capsule. And then we think about the CP angle and the IC, and we'll talk about this more in just a little bit. But a couple of years ago, we went through and reviewed every case that was referred to us for sensorineural hearing loss, and what did we actually find? And a vast majority of those cases, if there was a lesion, was vestibular schwannoma. There were some very rare lesions that we think about as kind of incidental. The patient was referred for sensorineural hearing loss. We did a study. We found a lesion, but we don't think that lesion was causing the sensorineural hearing loss. But that's just the idea of the spectrum of things that you might see if you look at these cases. So far and away, the most common was 90%. And again, this is not 90% of patients with sensorineural hearing loss have a vestibular schwannoma. If they show up at our center with sensorineural hearing loss and we do a study, if we find something, 90% of the time, that thing is a vestibular schwannoma. That's what we actually meant in the paper, but I see that misquoted and misinterpreted a lot sometimes. So that was the most common CP angular IC mass in our cases. They often present with sensorineural hearing loss. They may have tinnitus, and we want to differentiate it from these other pathologies in that case. Now, historically, we gave contrast on these studies, and we thought about an enhancing mass within the internal auditory canal. But increasingly now, at my shop, we just do a CSF bright sequence if they don't have any red flags. So if I have an older patient who could hear and then they lost hearing, if I don't have any red flags like increasing pain, other cranial nerve deficit, something else, a vesicular rash on the ear, then I'm just going to do a high-res thin section. So it's just an 8-minute sequence, and if I see a filling defect in the IC, maybe I go back and give contrast, but I at least know to refer that patient to a neuroodontologist. But I have these differential points where I check. Is there a fundal cap? How much CSF is lateral to the lesion? Does it go transmodular into the cochlea? Does it go transmacular into the vestibule, or transotic into the... So if we have a schwannoma along one of those nerves you heard about earlier, we look at these checkpoints to differentiate it from other pathologies. So that's our spectrum kind of that we think about with acquired hearing loss. So we think about sensorineural and we think about conductive. And that's a very important differentiator. If you say conductive hearing loss, I'm going to do a CT, and I'm going to think about the EAC, the tympanic membrane, the ossicles, the middle ear cavity, and the windows. If you say sensorineural hearing loss, I'm thinking about doing an MR, and I'm thinking about a problem from the windows, the inner ear, the CP angle, and the IAC inside. So that's a quick review of acquired hearing loss pathologies, and I thank you very much for your attention.